My name is Javid Abdelmoneim. I'm a doctor. I work for MSF as a medical team leader. I am half Sudanese, half Iranian. I was actually born in the UK, but I lived my first 8 years in Sudan. And I joined MSF in 2009. So it's been 15, 16 years now with the organization. I've been full-time MSF for the last 4 years. Really enjoying myself working in emergency settings with the emergency teams. I first heard about the conflict in Sudan. I'll never forget it. I was in Malawi working just after the cyclone Freddy and during the cholera epidemic there. And I was at my desk and I got a cryptic WhatsApp message from my cousin in Khartoum saying, "Your dad's safe." And I just thought, well, this is weird. I checked the news and it said, and there were videos of fighter jets flying over Khartoum and said that conflict had started between RSF and SAF. The war escalated instantly. It happened snap from that WhatsApp message on. It was throughout the whole city and then around the country because you had Rapid Support Forces, RSF, and Sudan Armed Forces, SAF, fighting for control of major cities, major routes, the airport, and people just needed to move out of Khartoum. It's not that Sudan has been free of war through my lifetime, but it's never been in the city. I didn't think in that first week or 10 days, I hoped this was going to be short. One of the sides would lose quickly. But it didn't transpire that way. And what ensued was just sort of the collapse of a nation, total collapse of a nation, really quite suddenly. It was, I don't have the adjective, it was moving. MSF is able to work in Sudan all over the country on both sides of the front lines, in both territories, RSF and SAF. Some of that work is a continuation of what we were doing before the war, but a lot of the projects are in response directly to the conflict, both at hospital level, at community level, but also in response to outbreaks of diseases like cholera, also for malnutrition. So not just direct violence related, maternal health, feeding programs. So when you look at the things that MSF are doing around the country, we're active in nearly all parts of healthcare, water and sanitation, preventative, maternity, malnutrition, surgery, on both sides of front lines. In my project in Omdurman, we were doing several things at hospital level and then at community level as well. And we were transitioning into much more focused care. So whilst we kept the logistical water and sanitation and incentive and supply package, we wanted then to focus with our staff, our MSF staff, much more hands-on inside the emergency room of a now hospital and inside the acute malnutrition inpatient therapeutic feeding center, ITFC, in Al Bullock Hospital. And that meant having MSF contracted, MSF's clinical staff in there looking at quality improvements. So we're looking at infection prevention and control, looking at proper waste segregation, looking at clinical knowledge of nurses and doctors, but also things like stationery, trainings and systems. And one of those things is the mass casualty incident MCI plan of and now. So how does the emergency room and the wider hospital pivot instantly from business as usual to responding to a mass casualty? That's a very technical, should be a live document that needs input and co-development. So we were doing that as well. So the war is close and people you know are getting killed or injured, be it by shelling or stray bullets. So that's a major challenge in that context because staff need to live and move around and safely work in the hospitals. And hospitals were a target as well. So, and now was a target and almost got struck a couple of times while I was there and had been hit before I was there. I'm the medical team leader, so I try not to be clinical. Actually, my day-to-day job is not clinical. I'm there to support and facilitate all the activity managers, the medical, the nursing, the midwife, activity managers, to do what they're doing. But I'm an ER physician and I'm trauma trained. So I would, whilst my nursing and medical activity managers would gladly go in and get hands-on patients, I would try to just sit above it and just identify who's the leader in this process, in this zone. How are we prioritizing which patient needs to go to operating theatre? So if I were to describe to you all the cases that I saw, they all died. That's because I was working with the blue and black cases. So I don't have a good story to tell in the sense of saving lives, but my push was, again, to make sure that they are comforted and having some dignity in their last minutes. And the second part of that was to make sure that the clinicians weren't doing too much for these patients to the neglect of the red patients who had a chance of surviving. You know, I've found in many places that I've worked that's like this. There's this sort of, the pressure, the siege mentality almost of working in a context like that, where there's a lot of stress and pressure, but the camaraderie that you build, the feeling of fulfillment that you get from seeing your work save lives, that combination actually brings about a very special sense of togetherness. So right next to our office, the next doorway was actually the mortuary. And the next doorway was the delivery room. So you had these most incredible sounds of death and life literally next door to each other. And the distances, I mean, the distances were, you know, this doorway to that doorway. You're talking three meters. So it's the most bizarre experience, in a sense, you know, and it's just, yeah, I had a few moments where I just paused, you know, by the tree and just took it all in, I guess. I hope for an end to the war in Sudan as soon as possible. It is Eid at the moment, and I wish next Eid that all my family have it in Khartoum. Personally, that would be amazing. Rehabilitation of the country. I think we've lost a lot as Sudanese. I don't know how close that is. I'm now waffling. But I think I said it with my first sentence. There you go.